Some people learn about a topic by books. Some people learn about a topic by documentaries. Some people learn about topics by going to evidence-based websites. The Prison Policy Initiative is a phenomenal resource. They do an analysis of mass incarceration, looking at all aspects of it every year. I'm drawing from the 2025 report. Anyone in this field knows an absolute mandatory text is Michelle Alexander, and the documentary on Netflix on 13th is really reflects a lot of what Michelle Alexander talks about. It's important just from the beginning to us for us to understand that the United States incarcerates more people than any other country in the world, whether it's democratic, communist, socialist, or a dictatorship. And I always say, if you want to know why, you got to follow the money in a capitalist society. And mass incarceration is like the medical industrial complex. It's like the military industrial complex. We have a mass incarceration industrial complex with huge amounts of, I would say, well over 182 billion. These were figures a couple of years ago being spent in this aspect of our economy. And as you can see, healthcare is it's maybe 9% of that amount. It's not the same as policing, judicial, or the facilities themselves, but it is dollars spent in this industrial complex alone. It's interesting, the data from 2023 showed that our facility structures actually decreased in size because of COVID. A lot of facilities were mothballed. And as you can see, the numbers were from before COVID. These are after COVID from 2023. But as I'm showing you this slide from 2025, those numbers are coming back up, and those mothballed institutions are reopening, and our incarceration problem is increasing again, which is a tragedy. If you want to know the history of incarceration, I am a historian. I study structural racism. I say it goes all the way back to the freeing of the slaves and the lack of manpower, woman power to work the land. The 13th Amendment has a loophole. It says the slaves are freed unless they have committed a crime as a free person, and they can be then resentenced and incarcerated. And so the birth of the incarceration system really occurred during Reconstruction. And I would say it was a way for the white power structure to gain a labor force to work the land. Michelle Alexander, in her book, The New Jim Crow, argues that the new problem of mass incarceration really is a form of neo-slavery in modern day attire. We didn't have this number of inmates that we do now, almost 2 million. As you can see, in 1860, we had 19,000. Right at the start of the war on drugs in 1980, we had 330,000. And within, several decades, we had over 1.6 million. Why? Because we had a whole series of laws passed targeting what was called the war on drugs, or the criminalization of the use of crack cocaine. Nixon calls drug abuse the #1 public enemy, but crime was low. Reagan declares the war on drugs, and Congress starts passing a whole series of laws, mandatory minimum sentences, the Control and Law Enforcement Act, which puts military equipment in local policing. We have the 3 strikes and you're out. So with each of these laws published, passed by Republican and Democratic administrations, we've got Nixon, we've got Reagan, we've got Bush, we've got Obama, and we've got Clinton, all have participated in this process because nobody wanted to be perceived as soft on crime. So imprisonment in this country is a problem of what Michelle Alexander says, and I would agree, is the threat of structural racism all the way back from slavery to the present. And we have an overpopulation of people of color, brown and black, in our prison system. As you can see, the US population, 60% white, with only 38% incarcerated versus African American, 13%, all the way up to 30%. And so this is a problem, we would say, of discrimination against brown and black people, but also the targeting of policing in underserved black neighborhoods. I'm medical director of our local jail. Michelle and Mark calls this the Cadillac of jails. It is a very unique setting. But I want you to understand that while 7 million people go to jail, two-thirds to three-fourths of those are never charged with a crime. They're held in that facility. Our average length of stay is 37 days. Most people are out within 24, 48 hours. But even that 24 to 48 hours can be enormously disruptive. And jails are the first entry into the incarceration system. Jails, state prisons, federal prisons. And people are detained often because they can't make bail. Our local system has eliminated cash bail. So the people that are in our facility, actually, we had 19 people charged with murder in June. So in many jurisdictions, bail is a um, form of advocacy for reform because the poorest are incarcerated at a higher rate, and therefore they can't make bail to get out. Okay, not only is bail a reason why people get stuck in jails, but incarceration itself is a contributor to disproportionate wealth between whites and people of color. Here you can see that not convicted, people that could not make bail increased in numbers in correctional facilities. And those that were convicted stayed the same or, didn't done. And that's because the median bail is set at 10,000, and someone has to come up with either 10,000 cash or they work with a bail bondsman, and it's negotiated down to 1,000. But if you're looking at poor people, they can't even afford that $1,000 for bond. And so they get stuck in a correctional facility until they go to court and get sentenced or released for no charges at all. So it's important to understand that the mass incarceration system has a huge footprint in this country. Not only people that have a criminal record, but family members who have a family member who's been incarcerated. There has been a Supreme Court ruling that healthcare is a requirement of those who are incarcerated, but it's dependent on local budgeting. It's dependent on the availability of well-trained health professionals. It's also dependent on your jail leadership and their advocacy for the full complement of health services to treat the medical, mental health, and social needs of these individuals. So we know from the literature, Emily Wang is really a brilliant researcher in this area, that there are impacts on the individual, there are impacts on families, there are huge impacts on communities. And I can't finish without saying that those incarcerated are less than those people who are on community supervision. And for us to understand, if you've seen one state in terms of who they incarcerate, who they put out on community supervision and probation and parole, you've seen one state, and they vary across the United States. So I want us to remember that 1 in 70 individuals on any given day is on probation, and that people on probation have a 3.4 times higher death rate than people in jail and people in prison. And I think that's because people on probation are linked to the legal system with no access to mandatory medical, mental health, and substance abuse services. And with that, I'll just end with this idea that there was a huge effort to decarcerate during COVID, and we were successful by decarcerating by 20 to 30%. But those numbers, as I showed you on that earlier slide, are going back up. And with that, Mark is going to talk about transition and alternatives to incarceration.
Thanks, Preston. I'm going to talk about, I guess, something similar to that, but I wanted to make sure that we talked a little bit about health policy, because this is a health policy class, and some people may have more or less interest in the legal system. But I think this quote's really great from an organization in New York City. And just looking at the first sentence, I think it speaks a lot to us as what we try to do in best practices in healthcare, which is to really take into account social context and history and try to understand why something is actually happening. So, oh, sorry, this is gonna be complicated because I'm not switching my own slides. So basically, like, I guess everyone has their own interest in this class. And I guess my spiel as to why I ended up personally interested in the criminal legal system's intersection with health was because if you look at all these different topics, really I see the criminal legal system as the intersection of really all these forms of inequity. And this is certainly a limited list, but so whether you really, really care very passionately about reproductive rights or drug policy, you can find the deepest of inequities in the legal system. And really, I would argue that you will not be able to really solve any of these issues without having a really strong analysis and interrogating the legal system. So a couple of just health policy related things that you may find interesting and or frustrating. They wrote into the initial passage of Medicare, Medicaid, this quote unquote like inmate exemption. And so the federal government won't cover the costs of care inside like prisons and jails. And that's problematic for a number of reasons. Like one, it introduces a lot of cost pressure. About 20% of the cost of running these facilities is the healthcare costs. And so there's a constant need to try to cut or desire rather to try to cut costs as low as possible in terms of the care provided. There's some kind of nuances to this in terms of if a patient ends up hospitalized, then sometimes the federal government will kick in and cover parts of the bill. These contracts are pretty complicated and somewhat depends on the institution, but also introduces some kind of odd incentives in terms of when jail or prison is willing to transfer someone to a hospital.
I'll also add, Nicole works with the aging population in correctional setting, and they are ineligible for Social Security. So when they turn 65 or 66, they cannot get their Social Security checks, and their families can't draw from it either.
And this is kind of really another issue that stems from the lack of the federal coverage is really nothing. There's no oversight. There's no joint commission. No one's really monitoring what's going on. And so there's very little transparency and almost no accountability. And I would say that more than not, the accreditation process that does exist, which is voluntary, is somewhat performative. And so it's a way of kind of deflecting criticism and eyeballs, but it really doesn't have much teeth. And you could look at my local jail, the Fulton County Jail. They were fully accredited 2 years later. They're under one of the worst Department of Justice investigations for conditions in the country. And so really it's quite meaningless. And what you can learn from that is that most of the conditions that are leading to poor health outcomes inside the facilities is often out of the hands of providers. So even if you have the best doctors, even if you have 50 Preston Reynolds, you really cannot transform the conditions because many of them are out of the hands of healthcare providers, which is why I would argue that it's just inherently a poor space to be providing social services. And the last quote on there is really just to show you that it's kind of out of sight, out of mind. And also, if you're criminal, if you're incarcerated, if you're a quote unquote inmate, felon, then it's an inherently dehumanizing process to the point where our government doesn't even care to track the number of deaths in custody, even though it's legally mandated. And so that to me is is pretty striking and shows that we don't even care to have even basic data to understand and analyze why these things are happening.
And I think the YouTube video that we had as part of the resources really highlights the aging population and the failure of providing resources at the end of life. And here you're not even accounting for people who die.
This was a somewhat long reading that we sent out in case you just were interested in digging in more to the health policy side as well. I mean, the vast majority of the local jails at this point, and increasingly some state prison systems, like in Georgia, it's all privatized. And so, despite the fact that most of the money is flowing to public employees, and it's really a public problem with only like 10% in private facilities, a lot of the contractors themselves are privatized, including the healthcare. And this is just kind of interesting the way that they finance it. And kind of the point of the paper, one of them is pointing out that like no matter which one of these structures the contractor has, there's often incentivized to minimize. There's often incentives to minimize the treatment that is provided. And so you see like certain restrictions around formulary. We see a chronic issue around people being able to access buprenorphine, methadone all around the countries. There's very few places doing this well, and a part of it is just from, again, the incentives and the cost pressures from private contractors. And a lot of locations, not all, but a lot, like in Georgia, we have a $5 copay in our state prisons for everything. And in Georgia, like you'll see here on the wage scale, there's a $0.00 minimum wage. And so people are usually getting paid cents per hour, and yet they still may have a copay to cover. So this really is quite pointless. It leads to care avoidance and leads to probably no cost savings overall. Like a couple of the papers that looked at this, there really is no cost savings. But it's certainly bad for people's health, and just introduces a really poor incentive system for what Preston mentioned with families and individuals who are already coming from really overwhelmingly disadvantaged and poor backgrounds. And this is probably like the hottest topic in the intersection of health policy in the last couple of years. So really, who knows what's going to happen with this during this administration? But people are increasingly using these Medicaid waivers to to kickstart coverage before people leave and help kind of improve a seamless transition, as well as reduce a little bit of that cost pressure on institutions. So between 30 to 90 days, people are starting to introduce these waivers to restart their coverage and start funding some services, and then have a much more seamless connection to the outside.
So our Virginia expanded Medicaid, our inmates, first 24 hours in a hospital is not covered. After that, it is covered by Medicaid. And that has made a huge impact on what we pay UVA to take care of our inmates who we have to transfer. So this is really substantial in states that have it. And an administrative staff in your jail who is actively making sure that that inmate is covered by that Medicaid program.
And so I think like for me, it's just helpful to zoom out and think about this whole kind of carceral continuum. And when we think about like how patients and certain patient demographics wind up inside the legal system, it has a lot to do with a lot of different actors. And the conditions inside jails and prisons get a lot of attention, maybe increasingly in healthcare spaces, because there's a lot of explicit healthcare taking space. But at that point, like, there's a lot of irreversible harm that's already happened. And so I think that it's really important for us to interrogate even the way that we think about our emergency response systems, why we even send police to certain types of calls, why there's so many crises taking place in the first place. And I mean, it really just comes back to how vulnerable the vast majority of our patients and the average American lives in the United States today. And so there's a lot of actions from people who get a lot less scrutiny, including from the judiciary and from district attorneys' offices, how they're charging to prosecute the types of charges they're bringing, that have a lot more implications for our patients than even people that end up inside the prison and jail system. And then, of course, increasingly, You see what I guess you could term as like a carceral creep, and this is really the way that different types of social service agencies have started to work hand in hand with the police and prison system in different ways. And this, of course, is includes like the family policing system, and really it just includes the way that you even access a lot of the basic social benefits have become very punitive and regimented, and it's not very, I guess, what we would call patient-centered in a lot of different ways. And there's a lot of hospitals that patients walk in the door, and one of the things their security in the hospital does is they run for outstanding warrants on their patients. And so, and of course, there's been a lot of recent concern around this with ICE as well. And so, even in our own healthcare spaces, we do a lot of the legwork for carceral state actors. And I think this quote, it just kind of speaks to what this entire system has become and the way that Alec Karkatsanis describes it as just a punishment bureaucracy, and that there's, hundreds of thousands of people working in this system, supposedly around the greater good, supposedly around public safety. And I mean, really, there's plenty of empirical evidence to say that it's doing a tremendous more harm than good. But most people, as an individual, um, are just showing up to work every day and don't have really a great analysis of what actually is happening with their system, which is really not that dissimilar to, I would say, our healthcare system as well. And so for me, this kind of gets to the crux of where healthcare workers stand in a lot of these discussions. And so about 10 years ago or so, James Kilgore popularized this term, carceral humanism. And it's kind of the idea of building a better cage, or as he describes it, which is really recasting police, prisons, sheriffs as these actually really caring social service providers. So that now, like, instead of this tough on crime rhetoric, you actually hear a lot of very flowery language of care. And so in Fulton County, for example, they were looking into building a new $2 billion jail. And their sales pitch wasn't, we're getting criminals off their street. What they were actually saying is that we're going to bring all this programming inside of the jail. We're going to do job training inside the jail. We're going to have more square footage in our mental health unit and all of these things. So, despite all the known harms of incarceration that are pretty intractable, they're really starting to increasingly describe these institutions as really useful, and not only like are they necessary for safety, but it's actually very desirable as essentially a community resource hub for the low resourced and disadvantaged patients and exploited patient bases. And so I would argue that really this is pretty perverse, and that no basic need and or public health intervention should be premised on criminalization. I think it's like the worst location and the least efficient way of getting people the resources that they need. And so there's a lot of very well-meaning people, and I would say in healthcare, and certainly many people disagree with me on this, but it really merits a much deeper discussion and structural critique as to how do we balance improving the conditions for people who are in the institutions today, whereas not committing an endless amount of resources and research and funding and relationships to trying to make these jails and prisons and institutions into something that they will never be. And with that comes a huge issue of what's known as net widening. And so as we have these like kinder and gentler forms of incarceration, and you start to see really the spread of things such as electronic monitoring, such as problem-based court systems for drug courts, for mental health courts. And so despite these seeming to be kinder and gentler than putting someone in a jail cell, what really happens is you end up with the infinite capacity in the jailing system. And what we know empirically is that coercion-based systems and punitive-based systems just aren't very effective, and they're more expensive. And so we should be really careful before we support things like this and think about the options aren't really a jail or a nicer jail, but really infinite, and that we can use our imagination and put our political clout towards finding, I think, better root cause solutions. And this is just to show that it's very relevant to everyone everywhere. But in where I live, like both in my local jail and the state prison system are under Department of Justice very recent investigations right now for pretty abhorrent conditions. And so in many ways, certain places are getting much worse and not better. So there's anyone that would tell you that the trend is towards continual improvement and things will get better with the Medicaid waivers is, I would say, somewhat naive and missing the larger picture. And this is really just a picture of my organization. And what we do is we do a lot of political education, but also community-based organizing around the jails and around expansion of policing and prisons where we live in Atlanta.
And so, if you are like most physicians, you probably have not learned about this sort of thing before today. And that was certainly my experience before I got into this work, is I realized I had never had any kind of formal education on this topic during medical school, during residency, despite having sort of, the kind of casual interactions with people coming from jails and prisons that I think most of us have had during our training. And so I sort of wanted to see if that was, my personal anecdotal experience was actually the norm or not. And so I did a systematic review to answer the question of like what education does exist out there for medical students, for residents in any capacity having anything to do with incarcerated patients, formerly incarcerated patients, at any level or any stage of their training. And, this, not going to go through this, but just to say, we did this formal analysis looking at papers from any time frame. We didn't put any sort of limitations on it, and to try to see what was out there. Next slide. And what we found is there's not much, which really, supported the kind of experience that I think most of us have had. There were only 49 papers ever published regarding education on this topic, and that detailed 95 different programs across the country, including medical schools, residencies, fellowship programs, up to date to 2024. So that's when the paper came out. And it was, about split half and half between undergraduate medical education and graduate medical education. Interestingly, in retrospect, this made a lot of sense, although I wasn't expecting it going into doing this study. But the majority of the education actually is psychiatry focused because of that mandatory learning competency of forensic psychiatry that they have, which is not even really care of incarcerated patients, right? It's just like, are they competent to stand trial? Things like that. And so really the numbers of what actually people are learning is much, much even lower than that actual number. And the good news was that 16 of the 49 papers were published just in the preceding 5 years before we started looking. And so I think there is increasing attention in this area. But even still, they're not necessarily learning as much as they should or what they should. So, there were some surveys of medical school deans where they reported that they felt only 20% of their medical students would be prepared to care for incarcerated patients at graduation. Only, and 2/3 of residency directors reported no curriculum or experience with incarcerated population. And then I think in terms of if we think about what the quality of that education is, there is really a lot of variability of quality. So if you go to the next slide, um, yep. So many of the curricula are pretty loosely curricula. They're really just like sort of evaluation of informal experiences that people may have with people coming in from local jails and prisons, that there would be no targeted learning about the specific health needs of this population, which I know we haven't really gotten into today, but I think you all can imagine that the people in this world do have a lot of specific health needs, no real focus on equity, which gets to the heart, I think, of what Mark was talking about of like, what are we actually teaching? What are we actually doing with our healthcare dollars and attention? And in fact, what that meant is that biases were being perpetuated. So people were being taught to view incarcerated patients as criminals and as professional liars, and that you couldn't trust them or what they would say. That medical students were being given less oversight, so they were allowed to do things in prisons and to incarcerated people that they would never be allowed to do to free world patients. That learners were seeing the neglected conditions of care that many incarcerated people live in, the advanced pathology that they present with because of their limited access to healthcare, and the fact that they're often not believed when they do present with symptoms. And in fact, that is echoed in what I found at my own institution. So I, have started doing a lot of education in this world at Boston Medical Center where I work. And prior to that, I wanted to survey to see what people knew who worked there, because maybe it's slightly different. We're a safety net hospital. We do get a lot of referrals from local jails and prisons. And that's reflected in the number. So 88% of people said that they saw incarcerated patients at least monthly, but still only 24% had had any formal education. And they wanted that. They felt that that would help them feel more comfortable taking care of patients, because they did notice, about half of people reported noticing disparities in care between incarcerated and non-incarcerated patients. And I suspect that's actually lower than what actually happens, but people don't necessarily want to express that they're seeing those disparities. And so that, if you go to the next slide, that really led to some educational initiatives that we're going to talk about today. And I think we're all doing various different things. So that's why we wanted to share the opportunities that are out there for teaching.
So I had a Leahp fellow 2 years ago who had done a rotation, I think at Rikers, and wanted to create an elective. And I was being lobbied by a medical student to do something in a local jail. So I put together, she and I worked on a curriculum, and then I modified the curriculum that she did. And what I do is I provide in a 2-week elective for fourth year students, and I now am doing it twice a year. Each time I can accommodate about 6 to 7 students. And we do 2 hours on the introduction to mass incarceration, looking at that whole pie, the history of incarceration, the Black codes, all the way up to the present. We do 2 hours on health disparities, looking at the chronic illness of prison inmates, the aging population, women health disparities. So we look at health disparities also as a poverty issue, as a health issue, as a gender issue. And then we look at it white persons of color disparity. We look at the whole issue of probation and parole, and also talk about the social determinants of health and how that predicts incarceration, and also look at alternatives to incarceration like transition clinics and other things that our Leahp fellows have worked on. And then we talk about barriers to conviction, barriers with convictions, and barriers actually make it harder to get an education. You can't get a Pell Grant, harder to get a job because you have to, often applications have a checkbox. Have you ever been charged with a crime? You're not eligible for public housing. So if you're married and your spouse is in public housing, you're released. You can't go into that home that you used to share with that person. You can't vote if you've been charged with a federal crime and served prison time. Your health insurance is compromised, your Medicare is compromised, and your Social Security is compromised. And then we have a conversation. We spent 2 hours with the superintendent yesterday, and we will spend time with the chaplain next week talking about the services that a chaplain would provide in that kind of a setting. And then our students rotate through all these different areas where we are providing medical services. Our urgent care, our intake, our chronic care. We have 2 full-time primary care clinicians, as well as myself, facilitating jail, UVA, test needs, follow-up, specialty care. We have 2 full-time mental health providers, as well as another part-time. We have started Suboxone. We do a diabetics clinic. We have medication pass twice a day where they'll go throughout the facility dispensing medications. And then we have a full-on dental clinic. And that's why Nicole and Mark calls my jail the Cadillac of facilities, because we have dedicated an enormous amount of effort and resources to creating a comprehensive medical program. And I rotate these students, and every day they have to do one of these different services so that they get a really good idea. And then I'm meeting with them every day to debrief their experiences, answer their questions, and make sure that the setting and their experiences are really optimal educationally. And now I'll turn to Nicole, who has developed a workshop.
Yeah, so I've created, I'll highlight a couple of the educational initiatives that I've done. One that I have am really excited about is nurse focused education. So as part of that survey that we had sent out, we queried nurses, and they talked a lot about the barriers that they see in care of incarcerated patients, as well as what we have seen is, their nurses, as we know, work a lot more closely interpersonally with patients than we as physicians do, right? And that perception of incarcerated people as inherently more dangerous can affect a lot of the care that they provide. And one of the things that I've learned about nurse education is they appreciate very brief, high impact modules. And so I was able to create a 10-minute session that's become part of the mandatory annual education for, we've started with the ICU nurses at BMC with hope to roll it out to the full med surg nursing complement. I based this education off of the topics that they highlighted in that survey, which were concerns about privacy because of the correctional officers at the door, concerns about patients being shackled throughout their stay, concerns about not being able to get information or give information to the jail or prison that the person's coming from. That people were unsure if incarcerated people can make their own medical decisions. And what we found is that, well, what I personally found is nurses are really great at completing surveys, much better than we are. And so had a pretty good response rate. And what they said is that 90% of them felt that the education did make them more comfortable working with incarcerated patients. And it also opened up some opportunities with that survey to see about how I can strengthen it going forward. But I think it really shows that there's definitely opportunity for interdisciplinary education in this space. And then the other education that I'll highlight is an elective for internal medicine residents that I created and that I've run through the last couple of years, where we're focused on having residents use their knowledge to complete compassionate release evaluations for incarcerated patients. So there is an opportunity for aging and ill people to get out of prison based on the degree of illness that they have alone. And this is a way for them to not become complicit in the, poor health care, but to use their knowledge to actually advocate for patients and try to decarcerate them and get them back out into the community. And this is just some, highlights of post-elective evaluations that residents have completed that really, I think, highlight a lot of the things that residents liked about the elective and have continued to like, that it offers them, a very different and unique opportunity to both advocate and transform people's lives. And they love being able to work on that concrete medical affidavit that is used to legally try to help that person get out of prison. And so it's been a really great experience, and happy to talk more about it, but we'll hand it over to Mark to talk about his education initiatives.
I'll also just add, throughout my seminars, I keep going through areas of advocacy, whether it's parole reform, transition clinics, drug courts, alternatives to incarceration, so that they come out of that 2 week knowing the breadth of areas that you can advocate for as a health professional.
Thanks, Preston and Nicole. I mean, I'll tell you about the curriculum on the next slide. This is just my community organization that we made, and it's explicit. It's a political education group in an organizing group. And so really our theory of change is that like healthcare workers, like they don't know about these issues. And oftentimes they know only a little bit just to be harmful. And kind of comes back to the carceral humanism and just thinking more critically about what we do and don't support. And if we are going to enter conversations, how we do that. But it's very much needed. A lot of these conversations and a lot of things that are happening around the country, not just in Atlanta, but everywhere, are very explicitly healthcare conversations. Like the biggest alternatives that people are looking for are investments in the way that we think about substance use and harm reduction and the way that we think about poverty and housing. And so, like, but unfortunately, healthcare workers usually are absent. And so, like, when I moved to Atlanta, there was a coalition of like 45 organizations, and there was not one healthcare group or anything really a part of it. And so, um, like the scoop curriculum, what we do at Emory School of Medicine, really, it's for medical students, it's for PA students, it's for public health students. Um, and it's a curriculum that tries to provide a really systematic critique. And so they have about like 4 hours of reading per session. Then we meet for an hour and a half every other week. And it's discussion based. So it's not lecture based. And so we talk about all these things and we talk about a lot of things going on in the jails and prisons and a lot of things outside of those systems as well. And so it's gone pretty well. We're in the middle of the second like cohort right now. We have about like 40 people that come and meet every other Tuesday. And yeah, so we work a lot on a whole bunch of different projects locally and with some students nationally. And the curriculum is really something that is meant to be like exported to other cohorts of people that can do it as self-led as they want with like a little bit of interaction and guidance from like myself or other people that I work with in Atlanta. And that's kind of like the theory behind the curriculum is to get people at least the nuts and bolts basics on a larger picture so they can figure out how on a local level to actually join into some of these conversations because all across the country, jurisdictions are talking about new police training centers, about new jails, about new prisons, about spending hundreds of millions and billions of dollars on fixing their current prison system. And I think we just need to stop and ask why, and then think about maybe there's a better way to spend those dollars.
So we'd like to go into breakouts, Mark, for maybe like 7 minutes and have people talk about if you were going to implement this, would you feel comfortable? Would you benefit if we created something and put it on GIM Learn? And what barriers would you
Preston,
face?
while you're talking, and so Francine can anticipate how many great breakout groups and for how many minutes.
3. And why don't we do them for 7 minutes and we'll come back and debrief for 5.
Thank you.
And I just want you to think about what barriers do you face in educating health professionals about correctional medicine? Is it knowledge? Is it buy-in? Is it space in a curriculum? Like Mark's is voluntary. He does it at night. It's not part of a curriculum. What format would work? Would a workshop work? Would a 10-minute module work? And if we created a GIM curriculum, would it be helpful? And do you think members in FGIM would use it? And what would you like to see in it? So your group can pick one of those 3 or all. Report out. We're back and I would like the groups to report out. I know what my group said, but I'll let other people report out my group as well. So why don't you just share on what barriers did you face? Do you think you could implement one of these? What format might be most receptive? And do you think SGIM members would like to have something like this on GIM Learn?
Yeah, we were talking in my group about a couple of different things, and with regard to your question, I guess like we were just talking about like my curriculum and like why I chose to not like try to integrate it into the student curriculum, like largely because as you know, medical school curriculums are very jam-packed. And then it comes with like a lot of like perhaps like oversight and editing that like I wasn't really privy to. And so But I think like we didn't get to finish talking about this, but in terms of like what is like most useful in curriculums, like it seems like a really basic requirement that every medical school and if not residency program could have the basics of how should you be treating a patient when they come in custody to your hospital, which is really largely missing. And it's like the most basic, lowest hanging fruit for people to just understand the basic rights and try to like stick up for their patients because at least in Georgia, like it's really horrific, like how it happens and people don't even get their privacy. And largely we do just become like an extension of like this carceral enterprise. But happy to hear what the other groups were talking about.
I think our group talked a lot about also the, you know, the limited education that a lot of people have had or have seen despite experiences taking care of incarcerated patients. And that often it requires like a champion or someone, you know, really invested in this work to getting it started. Um, and a lot of the questions that people have are, like Mark said, really the basics of how do you take care of someone um, in this setting. We didn't get to the if there were resources on GIM Learn, would that be helpful?
Vivek or Jackie, you want to report out for our group?
Yeah, echoing all that has been said, I think we share the sentiment of limited learning in this subject. I think also, um, th we had talked about ways and modalities to share this information. I think both the workshop and the module lend themselves, their pros and cons. Modules allow for some asynchronous learning for different physicians, maybe more for like faculty that are doing other work. But Jackie brought, I mean, workshops are, especially if you have the buy-in within your current hospital, maybe more hands-on, maybe actually a good venue to allow for more collaborative learning and get people engaged in conversations that lead to greater advocacy than just isolated module when you are just clicking through and just, you know, doing that. So I think that's really a good point. Um, One question that I was left with, which Jackie actually mentioned that Allegheny Health Network partners with Allegheny County Jails is just what that partnership with jails and looks like. And so how do you sort of ally with key stakeholders in a way that's not um, disingenuous to patient care and like with systems that may be facilitating or part of, the carceral system and complicit in mass incarceration while also understanding that they are important to be involved in these initiatives. And I just that's one question I was left with.
So my role specifically is to be that interface and to actually advocate for the needs of the patients within our healthcare system. So if someone comes to the emergency room and is treated poorly, I am in that chairman's office. If someone comes and is discharged inappropriately, I send them back and I call the attending. If someone needs a specialty referral, I make that referral. If someone needs a CT or an echo, I put that test in. So my role over the last 10 years has actually been that advocate, that that person gets the highest quality of care that they deserve as a person. And that is pretty unusual. And I think that's an amazing role for internists to play with their correctional facilities. It also gives you entry into that facility, and it also gives that inmate an entry into more specialized services if they don't have access to it. So, the problem is you don't want to be somebody who's colluding with, you don't want to be that correctional extender. That's why I also advocate a lot for reform. And, I'm a broken record of decarceration and not putting people behind bars to begin with. But fortunately, I have a superintendent who's even more committed to it than I am. And so our numbers are 30% lower than they were before COVID, and they stayed there. We're the lowest census that we've been in 40 years.
That's great,
So,
Mark. Thank you to you, to Nicole, to Mark. This is a great centering session to open up our eyes to these issues as a medical issue and as a health policy and education issue. So thank you for doing that. Our last webinar of the year is coming up in April, and it'll be a debate. We will remind folks the parameters for that. And then we gather in Florida. Looking forward to being there together. I sent out information about the presentations that we'll do that afternoon, trusting that if anybody has questions about it, they will email. And so great to see everybody in this ever-changing health policy environment we're in.